Good afternoon, everybody. On behalf of the Southern Illinois University School of Medicine's Department of Population Science and Policy, the University of Illinois at Chicago School of Public Health, the SIU Medicine Center for Rural Health and Social Service Development, and SIU's Paul Simon Public Policy Institute, I want to invite you to our latest webinar on rural health and the implications of the COVID-19 pandemic. This hour will be focused around COVID-19 and the rural opioid epidemic. And we're really fortunate to have an incredible panel that crosses sectors of law enforcement, the medical community, and social work to really think through issues around the challenges of the opioid epidemic, how the COVID-19 pandemic has affected those, and how we can really think about solutions moving forward. As those of you that have been part of our webinar series since April, you know that this is the 7th of 9 webinars that have been brought to you by our Illinois Rural Health Summit Planning Committee, those organizations that I mentioned. My name is Samir Vora. I serve as the chair of the Department of Population Science and Policy. Many of you have seen me moderating these panels in the past. And over those 7 webinars, we've tackled topics around an aging population, mental health, public health systems, nutrition and fitness, children's growth and development, rural health workforce. Today, we'll think about opioids, and then we'll end our last 2 thinking about healthy housing and economic development. The work that initiated this conversation today was part of an extensive effort made by those 4 organizations to reach out to leaders all across the state of Illinois, but specifically in our rural communities, to better understand and address the COVID-19 pandemic. 80 leaders from 55 organizations in fields such as public health, healthcare, academia, industry, government, met virtually to discuss how the pandemic is creating new challenges, but also fostering really unique innovations. Discussion forum participants were invited to additional sessions to identify common challenges and synthesize impactful solutions. The information, anecdotes, and issues raised in those conversations resulted in a series of policy briefs and have really been the foundation of these webinars. As we mentioned, those 7 topics, they've also come with 7 issue-specific briefs, along with a more foundational introductory brief that we launched in March 2021 titled Building a Healthier Rural Illinois, Understanding and Addressing the Challenges of COVID-19. You can dive deeper into any of those topics by visiting our siumed.edu Rural Health Summit website, where you can get a better sense of these issues before the pandemic, how COVID-19 specifically affected these sectors, and some ideas and policy recommendations moving forward. So now to introduce our incredible panel today. And as I mentioned, they come from very different perspectives, and we're hopeful that the audience will really get a unique picture into the different ways that the opioid epidemic is affecting our rural communities, but also how these unique sectors of society are trying to come up with different solutions to this really important issue. So first, I'd like to introduce Director Brendan Kelly. Director Kelly was appointed by Governor Pritzker and confirmed unanimously by the Illinois Senate to serve as the 8th director of the Illinois State Police in 2019. As director, Mr. Kelly leads a public safety agency of nearly 3,000 employees and 7 unique divisions. Director Kelly has led the statewide law enforcement response to COVID-19, 2020 civil unrest, and 2020 election-related security. A graduate of the University of Notre Dame and St. Louis University School of Law, Director Kelly has a wide range of experiences with law enforcement and public safety. Director Kelly, thanks so much for joining us today.
Thank you very much. Just to make sure I wanted to take myself off mute there. So thank you very much for the introduction, and looking forward to the discussion.
Yeah, wonderful. Next, I'd like to introduce Dr. Brent Jones. Dr. Jones is a board-certified family physician and member of the American Academy of Family Physicians, Illinois Academy of Family Physicians, the Christian Medical and Dental Association, and the American Medical Associations. Dr. Jones is a Harrisburg, Illinois native who delivers whole-life family medicine at Southern Illinois Healthcare's primary care office in Harrisburg. He is passionate about medication-assisted therapy in a rural context, having completed a fellowship with Rush University for this medical purpose. Dr. Jones, thanks so much for joining us. And then we have Mr. James Sparks, who's a recent Master of Social Work graduate from SIU Carbondale, where he excelled in his class, earning the Non-Traditional Student of the Year Award from the School of Social Work. While at Southern Illinois University Carbondale, Mr. Sparks received a scholarship from the Illinois Rural Health Association by writing an essay outlining his own unique struggles with addiction, serving time in prison directly related to his addiction, and how he overcame those challenges through recovery and education. Mr. Sparks is currently a behavioral health care manager at Shawnee Health Services in Southern Illinois. His next goal is to work to create freedom homes throughout the state of Illinois for those who struggle with addiction and might have the burden of a felony record. Mr. Sparks, thanks so much for joining us and sort of sharing your unique and important story.
Well, I do appreciate it. I'm honored to be here with you guys today, and I'm very interested and excited about getting on with this. I want to hear all of these special ideas from the other side also. I do appreciate it. Thank you.
Thank you so much. So now we'll kind of really get into the discussion. And, you know, Mr. Sparks, I'd love to kind of just start with you. To sort of describe, you know, the way you struggled with addiction and how you were able to think through some of the challenges around the opioid epidemic and how it sort of affects, you know, communities across the state, but sort of specific rural communities.
Well, I know that with my struggles with addiction, prison was definitely an eye-opener for me. And I had been introduced to alternative ways to get my life on track. And when I was backed up against the wall, I knew exactly what I needed to do. And that was for me to enter recovery. And that happened to be through Narcotics Anonymous. And while participating in Narcotics Anonymous, I have seen the opioid epidemic at its fullest and how it is happening now within this pandemic. There are a lot of participants in the adult redeployed program through Perry County, and I see them, I hear their stories, and the new struggles, as I like to see it, the new struggles that are coming with addiction and the way the world has changed through this pandemic. The extra pressures that have been added on us through the isolation and other protocols that we've had to go through. And it is definitely a whole new world out there. My adjustments are coming through listening, trying to understand where the struggles are really at today for the addicts of the world today, especially in the rural communities. It's definitely not like the big cities, but it is real down here in Southern Illinois. And getting into the social work side of this whole solution has opened my eyes to a couple different ways. We're going to talk about one of them, and that's harm reduction. I think that's very important. It gives addicts a way to at least stabilize and be able to be open to new ideas and solutions to help themselves.
And thanks so much, Mr. Sparks. Dr. Jones, I'd love to sort of, as you think about it from, sitting in a medical community, the challenges that, the medical community has faced with the opioid epidemic. As we have moved from really trying to understand the importance of pain management, but then some of the challenges that have come from the opioid epidemic afterwards. And so I'd love for you to kind of think for us and for the audience, sort of big picture, how has the way the medical community thought through the opioid epidemic, and specifically some of the challenges that you see with your patients as they come visit you in Harrisburg?
So, the opioid epidemic has been not a new thing. It's been going on for quite some time. I think we've just really identified it more recently, given it a name and started to really attack it as an issue. I think part of the issue for a lot of physicians and medical personnel for a lot of years has just been how to balance the need to help people who have true pain issues with the need to do no harm, right? That's our first call, to do no harm to our patients. And so over the years, you've had this dichotomy of trying to help people do well with their pain, trying to work their jobs, take care of their families, live their lives, and sometimes battle with chronic pain. And in the midst of that, we know 20% of those people who have exposure to narcotics are going to become an addicted person. And they're going to have ongoing issues with that, such that we have not only enabled that, but potentially caused a lifelong issue. And prior to more research and more familiarity in just, rural communities like Harrisburg, where I'm in, and practicing, there's been sort of an unfamiliarity within the medical community of what to even do in that situation where a person really doesn't have a pain issue to deal with anymore, but they have an opiate addiction. And so it's given a real dilemma, which has actually had patients seeking their care not from their physician anymore, which is the real transition that leads many people to using, medications that they've gotten on the street, to legal issues, to overdose. It leads to a transition of care to where the doctor's not involved at all, and in fact becomes almost an animus or an enemy type relationship. And it's something that we at our practice really wanted to change, and so we got involved with Rush and started to do some training with Suboxone and other things to do medical assisted therapy. And it allows our practice and those providers who do provide this to give an opportunity for those patients who have found themselves in that predicament, and those who, by other means, there are other means that people become addicted, but in those situations, we can provide a way of escape for them to actually start to live their lives again that in many ways this addiction has overtaken. And I like to use this example, and I'll kind of close this, with this, but if I'm a person who's very thirsty, it's been a hot day and I've been working hard and I'm very thirsty, we all know what that's like. And that drive to drink a glass of water on a day like that is an overwhelming sense, because it's in our deepest biology. It's driven by physiology. It's driven by hormones. And in that same way that it would overcome everything in us, when addiction to opiates is present in a person's mind, it will overcome everything, social obligations, job obligations, financial obligations, everything, until that's met. And so that's some of what medication-assisted therapy helps us to do, is reduce the harm, potentially overdose, but also helps to potentially give that person the ability to actually think with the rest of their mind about something other than just obtaining opiates, which is a great thing. We get to deliver their lives back to them, which is a wonderful thing to be a part of.
Thanks so much, Dr. Jones.
Yeah.
Director Kelly, I think part of it from leading the Illinois State Police, right, and thinking about, well, we have someone struggling with addiction. We have the challenges of, well, there's where they got there, the medical aspect. And I think a lot of things that we are becoming more innovative on and really saying out loud in ways that even Dr. Jones said with the opioid epidemic of, well, there are a lot of linkages where medical challenges and law enforcement intersect, right? And often in ways that the opioid epidemic is one of those things that has really brought that to the surface. I know this has been a really important issue for you and the Pritzker administration overall. Can you speak to a little bit of how the state police has been thinking about the opioid epidemic even before the pandemic, and some of the ways that officers and kind of the apparatus, both locally and statewide, have been adapting to as we learn more about how people are struggling with addiction?
Yeah, absolutely. So just, big picture, to your point about what we share in common with people in the medical profession, as well as people who are involved in public safety and anybody involved in social work. Obviously, we're trying to save as many human lives as possible. We're trying to reduce harm. We're trying to make sure people are safe and that we live in a just and a safe community. The big picture with this opioid challenge is that in some ways some mistakes and maybe bad choices and a lack of forethought and monitoring when an excessive amount, I think we'd all acknowledge that an excessive amount of overprescribing for a variety of ailments that people were dealing with medically, and unfortunately a negative pressure that came from certain parts of the pharmaceutical industry it set the stage for the now non-prescription opioid crisis that we're dealing with. We still have an ongoing issue with a prescription addiction, but we're obviously dealing with some very important challenges that we deal with on a daily basis within the law enforcement community in terms of the ongoing crisis we have with opioids, and it continues to evolve. Much like we've seen this variant of COVID. There's the Delta variant, and now what's the next thing? We've seen this opioid crisis unfold in stages, and no doubt the rural parts of this state and this country have been tremendously negatively impacted. The Illinois State Police are obviously a statewide law enforcement agency, but we also are in a unique position where we oversee all of the drug enforcement groups and task forces within the state. So we indemnify them, we oversee them, we administer them, we're part of them. And it's a big priority, a big part of that three-legged stool, if you will. We all know education is important. We all know treatment and prevention is important. But there is an enforcement aspect to it as well. Giving people a chance to succeed in treatment, giving educators a chance to create the space to encourage awareness, and so people are prevented from going down this path in the first place. Giving those things a chance to have some effect cannot take place if you have this continuous, overwhelming surge of availability of heroin and fentanyl that's coming from a variety of places into the state of Illinois, that is finding people who are going to use heroin and fentanyl, not just with people that maybe are being limited in terms of their prescription access. Once it's determined that they have an issue and they may be doctor shopping, or someone figures out that you shouldn't have access to these particular prescriptions anymore because you're not just using them for legitimate health reasons, they'll turn to these other illegal sources. And the availability of it is unfortunately ubiquitous in many circumstances, and that's what law enforcement has a role in. It's clearly, obviously, the people that are profiting off human suffering, and making sure that there's accountability and there's a measure of enforcement there. Again, to give those other two legs of the three-legged stool a chance to work. During the pandemic, every part of society was affected. and we saw a sort of withdrawing of a lot of the things that we were able to do in terms of social services, in terms of support services, medical community focusing on COVID specifically, and not some of these secondary things like addiction or the other things that are complications from addiction. Law enforcement as well during the early stages of the pandemic, we didn't know what we were dealing with. We didn't know what the threat was going to be to our people. We didn't know how dangerous it could be for them. And obviously we've had a lot of law enforcement killed in violence recently, but the number one killer has been COVID. So there's been a bit of pulling back as a result of that. And that has created, a temporary space where some of the illegal trafficking that is part behind this cycle of addiction has occurred. But now we're engaging more, but not just in the traditional law enforcement way where it's just, lock people up and throw away the key. We know that that is not particularly effective when we're dealing with the cycle of addiction. But doing what we can when we're engaged with people, when we come across people in the law enforcement context who have or are suffering from opioid addiction, and being able to not just use the traditional criminal justice process, but also to divert people and defer people and have an alliance and work closely in a co-responder model with professionals that have a social services background, that have a medical background. Law enforcement doesn't want to see the same addict over and over again, suffering and being put in very dangerous situations. We want to see them break that cycle of addiction because that's part of the supply and demand that we're trying to attract. We want to see them become healthy. When we don't want to see them back in the criminal justice system, but oftentimes there has not been a connection between these various fields that need to be talking to each other and working together. And we have 3 pilot programs going on across the state for that co-responder deferment type of program. We were giving those wraparound services, and we're excited to see how that's going to work. And 2 of those pilots are occurring within our drug units, specifically working with opioids, but also meth. And we'll get to it, I'm sure, in the conversation. But we're seeing an overlap in these various cycles of addiction between meth and opioids.
And thanks for that overview and that distinction, right? The education, the prevention, treatment, and then the law enforcement. I think part of even the hopes of this conversation and kind of the work moving forward. So how do we think about, tying those things together? And so would love to kind of, hold that thought for just a bit and then really kind of dive deeper around the challenges of the pandemic. And Director Kelly kind of mentioned those, right? That our inability to have some of those social services, the medication, the personal relationships that are often really critical and sort of engagement, and often in virtual spaces that the rest of the society moved to that couldn't be moved often in cases around enforcement or prevention and treatment. Dr. Jones, a part of this was a cycle of, well, how do we think about care virtually? And I'd love for you to kind of speak through, because what we saw, that between 2019 and 2020, fatality rates increased 33%. The highest levels of, opioid fatalities and challenges were at the peak of lockdown. And did that seem were those patients just gone? Were you able to see them, or was the practice able to use virtual mediums in new and different ways?
I think we initially had the same concerns that, these patients who would traditionally come in sometimes weekly for drug screens, continued support, counseling, a lot of around care to help them be successful in the programs, would, in some weeks or times not be able to come in at all and would be much less able to meet the standards of coming in if they got sick, if they got COVID, if they had these other things come up, and even if they had an exposure, which, as we all know, happened a lot over the last couple of years with, any of our lives. So what we've had to transition to, and even, major addiction specialty groups have given the okay to do during this time, is use a lot of virtual visit to help supplement what we would usually do through the office type visits, using, in-person discussions, in-person drug screens and such, to just do, video visits, even for initial visits, which again, that's probably the one that's the most difficult to do, to really, ascertain, is this person really using what they're saying they're using or not? To just go ahead and to use the term that Director Kelly had used, it's exactly right here, to reduce harm, to just say, let's go ahead and go for it, and just, give them the benefit of the doubt. They're here to get care, and we really want to try to use that as sort of a first approach, and get them in here as quick as is feasible and as safe. And that approach has worked well. And I think, to the other point that you mentioned, just with higher levels of need and higher levels of fatalities related to this, I think we've seen a much higher level of need during this time. At least to speak to our level in our rural practice of number of patients, we have had an explosion of the number of patients who have needed this care, come for care, and it's come through a time where you would expect that people would want to stay out of doctors' offices. We've had a huge number of patients seeking out first-time opiate use disorder care through the pandemic over the last, year and a half. So, in a sense, that's been really encouraging. But I think in another sense, it wouldn't have been an opportunity available had we not transitioned to kind of more liberal opportunities for them through the virtual visits that I described, and through those abilities to get there, which I think is a good thing. So,
yeah. And Mr. Sparks, we had kind of mentioned harm reduction services. You had kind of brought those up, and have kind of been continued in the discussions for Director Kelly and Dr. Jones. Would you be able to kind of describe those a little bit for the audience? And what do we mean when we're talking about harm reduction services for addiction, for opioids in particular?
Okay, so we have MAT doctors here with us at Shawnee, and one of the first stages of harm reduction is when a patient comes in, like Brent was just saying. There has been an influx in those types of patients. Addicts are getting to their wits' end, whether they became addicted through typical pain treatment, or if it was from the street drugs, as has been mentioned before too. If we can get a patient on a medical assisted treatment program, Suboxone, they are less likely to use the more dangerous street drugs. This can prevent overdose, whether it be from a really potent drug or one that has been tainted with fentanyl, which is a potent drug. But when you think you're buying one thing and you just don't know exactly what you're getting, and I'm speaking from an addict's perspective here, we're going to get what we want to get, and we're going to get it the way we need to. It can reduce that harm and that reduce the possibility of overdose. And in reducing that, again, we can give that patient a better chance to clear their mind, because they're not on bad drugs. They're on a controlled substitute, and they are more apt to hear other solutions that can be offered to them, such as behavioral health treatment. Behavioral health and substance use disorders go hand in hand, and they are locked together. We don't know which it is, the chicken or the egg. Was it the behavior, or was it the substance use that came first? Getting this type of treatment can allow a person to study their own behaviors, figure out what is within them that is making them want to change how they feel. That's all we want to do. If I feel pain, I want to change that. If I feel trauma from a previous upbringing through my childhood, whether that be sexual, physical, or emotional trauma, and we are finding out that a lot more of the world is suffering from this kind of trauma. Whatever it is that we're trying to replace and fill that void, there are other healthier ways to do that. And we give those patients a chance to figure that out. And I wasn't quite sure how I felt about MATs at first when I came into social work. But I was led right here to Shawnee. There's no coincidence, definitely no coincidences in my life, but there's no coincidence that I ended up here. And I have been embracing ideas from the OBOT doctors here, and they have been really picking my brain and trying to figure out how to help their patients through my perspective and through other substance use disorder counselors' perspectives. And it's slow coming, but I think we're onto something here. And as far as this pandemic, the use of telehealth was a plus, and then for some of our patients in our rural areas who did not have access to quality technology, that got very limited. Brent, you can probably attest to this. When we could not come into the offices at all, the toxicology reports to make sure that the patients were taking their medications correctly got out the window. Patients were cut off. That causes them anxiety. We go back to what we can find in the street drugs. There was maybe a little bit more or a little bit less relapse, depending on how that went. But I think the world as a whole and our state policymakers did an excellent job at implementing the telehealth, and the insurance companies cooperating. And I hope this continues because it is a better way for us all to stay connected when we can't get face to face.
And Director Kelly, I'd love for you to kind of jump on this point, and you, as you wrapped up your last set of remarks, we know what the pandemic has led to those challenges, right? People feeling a number of sort of trauma and stress from the pandemic, the influx of, certain substances. And how did, from your role and thinking about the entire state, both urban areas and rural areas, how did you think through, well, how do we approach this really complicated, unique problem that was already a unique and complicated problem before the pandemic, but really created an environment that people had to learn how to do their jobs very differently?
Well, I think in a couple of ways. Obviously, some of the work that law enforcement does has to be hands-on. You have to be present. You can't lock down perpetually the basic operations and processes of law enforcement. You have to be able to respond to those things. So we work through those issues in terms of being able to protect our people and appropriate social distancing, masking, other measures that we take. Everyone in the Illinois State Police are qualified emergency medical responders. So having medical protocols as part of the framework of doing the work was not necessarily very complicated for us. In terms of the daily process, what we're doing right here is an example of something that would not have been done before the pandemic. We would have been sitting in a hotel conference room somewhere, huddled with whoever wants to show up, and having this, this panel, this, question and answer session, this discussion, not doing this type of video conferencing where it's frankly a lot easier for us to participate, and for anybody else who wants to participate can do so. So there's been many good things in terms of how people manage their daily routine, how they manage the flow of information, how they manage communication, like, again, what we're doing right here as we work our cases, as we share information, as we try to coordinate, as we build out the pilot projects for our co-responder models. It's all been done largely electronically. It's not a lot of it. It's been done in person. It's been getting all the key stakeholders together and having this kind of communication, building out this process. But frankly, in some ways, our productivity has increased, our ability to do the work that law enforcement needs to do, and our communications with people in the medical world, people in the social services world, people in the broader health, public health world has increased as a result of being forced to try different things. I think the co-responder models that we're building out, I think, is going to be an interesting example of a variety of forces that were at play here in the middle of of the pandemic and COVID. We had a great degree of civil unrest, a lot of conversations about what people expect of the criminal justice system, some very intense debates on that, but perhaps some good common sense things coming out of it as well. And one of those things is an expectation by the public that all these various entities, a multidisciplinary team approach, is what they expect to some of these challenges. Always will be a role for law enforcement, but partnering with these entities is going to be important. But I think as we've had to be more creative in dealing with a variety of converging and confluencing social problems and social ills. We've had to be, frankly, more nimble. We've had to be more creative and think in ways that we didn't before. And certainly that's appropriate given the fact that the challenge that we're dealing with is as equally complex. There is a convergence, as I mentioned before, of people who may be using cocaine, for example, or what they think is a prescription pill that has been sold in the illegal market, but actually is laced with fentanyl, an opioid, or folks that are using methamphetamines, and there's also fentanyl in the methamphetamines, or vice versa. There's an interesting mix occurring of opioids as well as other stimulants and other drugs. And that is also occurring while we're seeing an increase in drunk driving. We're seeing an increase from out of state coming into Illinois, the presence of illegal cannabis, not the cannabis that's medically monitored, not the cannabis that's part of the state's highly regulated adult recreational use process, but cannabis coming from other states and other countries, also having other substances in them. So the spectrum, the variation, the cornucopia of possibilities requires us to be as equally creative. And I think in some cases we're meeting that, but by some measures, we still have a very, very long way to go in dealing with the opioid crisis and the overlap, all these concentric circles that are kind of overlapping with each other, all these other social problems. And we have a lot of progress to make because people are still dying at an alarming rate. We have this pandemic, but below the surface is still this epidemic, which has only increased, and the two layers of this problem have interacted with each other.
Yeah, and I think that's completely right. But so how do we think creatively, know what the challenges are? And I think partly through our Rural Health Summit series, what we have seen is that these 7 topics that we've discussed so far are seemingly very different, but they're all connected through different layers of, well, how do real innovative partnerships, new ways of thinking, how can we kind of begin implementing those? Sometimes even more challenging in rural communities where the foundational infrastructure can be limited. And so would love to kind of go through and begin just sort of putting up on the screen the recommendations that came from this brief and through our discussions. What we continue to see, and both Mr. Sparks and Dr. Jones had mentioned that the real importance for MAT, medication-assisted treatment, and the availability for MOUD centers, medication for opioid use disorder. Part of that is how do we think about ways to enhance virtual treatment and remote counseling options. But in some of the work, Dr. Kelly specifically stated with law enforcement, but I think in other areas too, where virtual modalities aren't often perfect. So how do we begin creating the right kinds of intersection of those things, knowing that the ability to provide virtual treatment in rural areas where the geographic space is so great is really something that we have to kind of move forward on. The second recommendation of thinking through justice-involved populations to reduce opioid use disorders. I think that's a real unique group of individuals who are leaving jails and prisons. From our research, are a big range of 10 to 40% more likely to die from an opioid overdose than the general population. How do we think through different strategies And some of this work is being led through the Illinois Criminal Justice Information Authority as well. And then finally, we spent the beginning of the discussion a little bit bringing into this idea of how do you sustain and dramatically expand harm reduction services into rural areas, naloxone centers, thinking about needle exchanges. And what we've seen really through this, and especially in deep Southern Illinois, the challenges that have come through from items like and diseases like HIV and hepatitis C, and some of the ways that the opioid epidemic is leading to some of those challenges around chronic disease and infectious disease as well. During this time, we'd love to also open up the Q&A box for panelists. So if one of our attendees has a question, please kind of pass those through the Q&A box, and we'd love to be able to kind of bring those up as well. And so I'll kind of go to the panel. You know, none of these ideas are ground shattering, right? Because I think what we have talked about so often in our conversations now is that we know that we have to work within our groups to think creatively, because we know what some of the solutions look like. It's just the difficulty of coordinating and being creative to get there. Would love to kind of hear your reactions to these through your different work. Well, how can we kind of get these different ideas and put them into motion in terms of implementation? And Director Kelly, maybe I'll start with you this time.
Well, that's a big question. I think some of the items that you've laid out there require, again, kind of, you know, what we're doing here, which is a continuous dialogue between all the various stakeholders, and it can't be a one-off. I think that's the biggest challenge that I think we see with anything the government does, or anything that's led by government and involving the various, you know, sectors of the community, various stakeholders, is sustainability, keeping it up, following through on it, and making sure that the process continues. I think where things break down is when there is a lack of continued dialogue on that issue, and there's a lack of clear metrics. I think making sure we have good data, a good sense of what the goals are, a good sense of what it is we're trying to accomplish, breaking it down. I mean, big picture, too many people are dying of opioids. Okay, that's a complicated issue. How do we break that down into the various components of what's driving it, and then have agreed upon metrics to hold ourselves accountable for whether or not we're having an impact on that? Obviously, the big number is how many people died. But are we having a measurable impact on the various components that are contributing to that? There's no, you know, Hail Mary pass here for this. This is a game of inches, yard by yard, you know, getting into the end zone. And it's going to take all those things adding up. And that's, you know, just a broad perspective about how we probably should continue to approach it.
Yeah, and a great one, right? So how do we go from, you know, we know what ultimately the end metrics are. And Dr. Jones, well, so how do we think through, you know, different ways, and I sort of think about it from your medical perspective. Well, how do we kind of continue to engage in this dialogue, right? Because I think part of the challenge is that across sectors, we have our own metrics that sometimes don't converge. And how do we figure out ways to be able to share that information in different communities, because the work, you know, happens locally, to really make and affect change? And how can we think about Harrisburg being an example where we could put some of these ideas into motion?
Well, I think one of the ways that we have to think about this is if you have an opioid treatment desert, then you're not going to have any change in the dial. And so if you have no one in a whole county, for instance, and there are a lot of counties in Southern Illinois where that's still true, who's providing any MAT therapy, then we're not going to see much of this happen. So you're not going to have much change in your overdose levels, because there's going to be a lot less Narcan prescribing, even if your primary care doctors are educated about the need for Narcan for their, hydrocodone patients or Percocet patients, the risk is still very high despite that. And so to have, doctors who are trained and ready to do Suboxone, and by the way, anybody can do that. It's just an X waiver and it's, an online process and it can be done. And SIU is doing some training. Rush is doing training. I mean, so part of it is more providers in every area doing this. And I think that accomplishes the second feature of what you had asked, which was how do we decrease the number of infection rates? That comes with it. When you have more providers in these areas doing these things, part of the standard of care in doing medication-assisted therapy is we always check every patient who comes in for HIV and hepatitis, every one of them. And so they're going to get treated for those things if it's found. And so you're automatically decreasing the rates of transmission just by knowledge about that. Most of those patients have never been checked in their lives. And so they may have been passing it along for you don't even know how long until that moment when they're actually checked. And suddenly we can get them set up with, treatment options, sometimes within our own clinic to just take care of it at that moment, which is a great thing. I think the last point is a great one for this forum, and that's the discussion about justice. And you quoted 10 to 40% higher risk of overdose with those who have a justice-related background. I would say one of the policy things that I would like to see potentially change, or maybe an ongoing conversation, is even locally, and we've had conversations with, police departments, jails, et cetera. But even if a patient goes into a facility on Suboxone, that is oftentimes stopped while they're there. And I know many who go into, an imprisoned situation, et cetera, will have, an alteration of their medicine such that there's either use during that time or some sort of other story that's told after the fact. And then when they leave, if they go and try to use again, they expect to be able to use the same amount as they used prior to their incarceration. And that's what leads to the extremely high level of overdose, because their body is no longer able to handle that. And it leads to a lethal dose, sometimes the very first time they use right after incarceration. So it would be a great ongoing conversation to have there, just even at a local level, to say, how do we engage even local jails, for instance, on the safety of administering Suboxone? How do we participate in that such that we continue the care that they've already been provided, so that they don't go into total withdrawal during the day, 3 days, 5 days, week that they're incarcerated, and then leave, and we've set them up for failure just trying to do the right thing from a legal standpoint.
Yeah, no, I love those suggestions, and part of, I think sometimes it's just the different dialogues and perspectives of, as different groups are viewing the issue differently, how can we kind of add to ultimately all of our interests, right? To do what's best for the citizens of Illinois, and then ultimately sort of prevent those deaths. As all these conversations go, there's so much to talk about in a limited time. And so we're already to a point where we've got 10 minutes left. We got a couple questions from our audience, which we'd love to get the opinion of the panelists. What are our panelists' thoughts about safe injection sites? And so part of this is kind of a two-part question, that being one, and that one is a harm reduction measure. Others of, opioid alternative programs. Some have, even as this questioner asks, thought about supplementing marijuana for opioids. Have people kind of experienced that in clinical, or thinking about safe injection sites? Would love for the panelists to respond to kind of those two different sort of questions there. And we'll start with safe injection sites.
From the standpoint of just, safe injection sites to provide one-time use needles that we know are not going to be contaminated, I think that there's definitely evidence to suggest that's a great harm reducer. It is certainly, from the standpoint of Southern Illinois, going to be a socially interesting thing to try, but I think would still be a harm reducer for those particular areas maybe that we think would be most effective in. So I think it would certainly be worth a try. It would just be, highlighting what areas you think would be best to do it in that would be most utilized, since the spread here is different than, doing it in Chicago, doing it in Peoria, doing it in St. Louis, where you have a much more concentrated population, where you could put it in one spot and connect with thousands of patients. It's going to be much harder to do that, in Harrisburg, where that's going to be a harder thing to really utilize in an efficient manner.
I think it would need to be done as you're considering that concept and where that may or may not be appropriate. There's a couple challenges I think that we have to be cognizant of. I think there is not a lot of information or awareness about what the function of that type of clean needle exchange would do in terms of the impact that it might have on where that particular type of resource would be available, where that particular type of operation would be occurring. You will encounter then in many communities and within law enforcement a lot of concern about, does that create a magnet in a community wherever it's located for co-occurring drug activity. There's concern within those communities about what the implications are by having increasing the chances that you'll have the flow of people who are actively involved in an activity which is by in and of itself against state and federal law. But I think what has to be communicated and what there has to be a dialogue about is what is the trade-offs that you're getting there, and does anywhere within that process, is there any incentive for treatment? Is there any incentive within that type of process to divert people into a treatment process that will reduce the activity that we're all trying to reduce? If it's simply sold as a, hey, here's your free needle, have a nice day, at least you're not going to get hepatitis. That's going to be a dynamic which I think a lot of communities are going to struggle with in terms of the trade-offs that they may perceive. And I think you have to get strong evidence, you have to have strong data, you have to have a good community buy-in for something like that to work, because there will naturally be a degree of skepticism depending where you are and depending upon how that particular type of operation may play out in a given community. So there's some challenges there with that, and I think one of the things that's often pointed to with that type of exchange is the collection of data. We have to have data to understand what's going on in the first place. But most people in the community are not necessarily in it for the scientific, curiosity. They don't necessarily connect the dots of collecting the data with, this is what's going to keep my community safe. And I think that's part of the challenge of the dialogue on that type of initiative.
Yeah, great points, Dr. Kelly and Dr. Jones. I think part of through all of this, right, the complicated nature of the actions that are taken too, and what are the intended effects, what are often sometimes the unintended consequences, and how do we kind of use data to inform actions? And I think part of the other thing that we've been trying to aim for through these webinars is, well, how can our university partners that are thinking about these bigger issues also in ways that the work is really meaningful to the important decisions that are being made, both on a practice level, but also on a policy level. Let's take one more question from the audience. And Dr. Jones, this might be most directed to you, but would love kind of input from others. Does poor access to specialists add to the problem of the opioid epidemic? And in parentheses, the questioner asks, addressing pain through cheaper primary visits versus testing and specialist visits to address the real problems?
I think I can understand what the person is trying to ask there, specifically saying, if you can't see orthopedics, if you can't see a neurosurgeon, if you can't see a pain management doctor. And I don't know that I can, attest to any particular study where I've seen that being the case. However, I think it comes back to maybe a point Director Kelly had made just about, the overprescribing of narcotics as a general issue. And I think that does bring us back to sort of a practice level issue in medicine that we're trying to address at a nationwide level. And that is to just say, there was a time where it sounds crazy to say this, but I really think physicians were more apt to just say, you've got this chronic pain. Let's just give you this pain medicine that will at least alleviate that. And let's move on to the next issue, your blood pressure, so forth. And the reality is, even as this question suggests, there are really so many things we can do for people with chronic pain these days that in many cases can maybe not alleviate it in a non-narcotic fashion, but can certainly address it in a way that would help them get quality of life back that doesn't lead to these risks that come with chronic narcotics. And so whether that be through the utilization of some surgical or non-surgical approach with a specialist, or even with their family doctor, just digging in a little further before we go straight to a narcotic as the all-sufficient treatment plan, I think it's gotten to a point that we have all had to ask ourselves, is that the approach that we are using or not? And if that is, we've got to dial it into something much more specific to that patient. So I hope that answers the question.
Wonderful, Dr. Johnson. So we're running out of time, 3 minutes left. Would love for each of the panelists to kind of give some closing thoughts to the audience. Dr. Kelly?
Well, I think, as I said before, this is a very complex problem, and obviously we're talking about the impact more directly on rural communities, but it is not isolated to rural communities in any way at all. It maybe disproportionately impacts rural communities because of the lack of resources to counter some of the effects and the lack of access to those resources. I think that we have to think about it in a complex way and really ask hard questions about the data, not come at it with any preconceived notions from whatever our positions are in life, whatever our preconceived attitudes are about it, but look at it very forensically, look at it in terms of what does the evidence really show. I know one of the questions that was posted in here was about the interplay between cannabis and opioids. If the theory was posited that, if you have cannabis, people will use less opioids because they have cannabis as an alternative pain management or whatever the case may be, and that will reduce opioid use. Some studies show that. Obviously, what we're dealing with in the state of Illinois right now, you look at the data where there's adult recreational use and opioid use has gone through the roof. So what is the correlation there, if any? However, we're also we're not an isolated island here. We're dealing with many states around us and within a federal context that there is no rhyme or reason to what's going on or consistency in terms of cannabis policy. So is that a fair metric? It's just an example of how complicated the problem can be. You ask one question, you have to ask the other, and then the next question. It can be difficult, but we have to do it if we're going to get things right, and we have to do it together with all the various stakeholders.
Yeah, Mr. Sparks, we'll give you kind of the last word here.
We do know that this is a very complex, complicated situation. There is no one answer. I think with the medical, social, and justice side of this, as we have more conversations like this, we can start to work together a lot better. I think the justice side has seen that the average addict does not need to be thrown in prison. Also have started seeing from the medical side that we can detect when a person is coming in for chronic pain rather than just being an addict. We treat them differently. We treat them in the same manner to try to alleviate their problems. And we are being able to be more focused on that. From the social work side, what I like to try to do, and from a counselor or a therapist point of view, is to help work on the behaviors that drive us towards those kind of things. Whether we started out with somebody with chronic pain and have become addicted, we look at where that change initially started and try to get back to a normal mindset. And that is part of where, and I'm going to touch on this briefly, this is not an advertisement. This is where I think better treatment centers would come into play. People who have minor felonies who come out of incarceration need a better place to go than just a halfway house or a sober living home. They are too short term. I think a little bit more structure and a little bit more guidance and help with daily things in their lives, such as changing the behaviors and offering a variety of services all in one place, could be a little bit of help with that. I'm not saying that would help everybody. There's no way that I could promise that. But I think that we are all working together for a common goal. And I think it's getting just a little bit better. We just need to stay one step ahead of the addictive thinking in this. And that is a very difficult thing to do.
Great comments. And I think part of it just, there's so much here and so much important discussion as we kind of run out of time. Thank you so much, Director Kelly, Dr. Jones, and Mr. Sparks. A lot more to discuss around the opioid epidemic, both in rural communities and across the state of Illinois. And thank you to all of you for your leadership and being part of this important conversation so we could share it with our audience for the Rural Health Summit. For those, our next webinar, December 16th, 2021, right at this noon hour, where we're going to be talking about COVID-19 and the effects around health and housing. So we hope to have you participate around that important topic. Thanks again to our panelists, and we hope that everybody has a very safe and happy Thanksgiving holiday break, and we'll see you all in December.